Thank you very much for asking me to speak. I'm Rumana. I'm one of the consultant ocular oncologists up in Liverpool. And basically, uveal melanomas are what I quite commonly see. And up in Liverpool, I'm sure you all kind of know about how we do quite a lot of prognostic biopsies and things like that. But I'm going to start with the quite basics first, just to make sure we're all on the same page before I get into some of the specifics of the topic that we're talking about. So, um, if I give you a little bit of background, you know about uveal melanomas, and in the past it was considered that small uveal melanomas aren't particularly dangerous, and so a lot of people would just kind of sit and watch them, see if they grew, and if they grew, then maybe they would treat them. And there's a number of reasons why that is, and I'll go into the details of that. And then the larger tumours people would treat with various methods, whether it's radiotherapy or surgery. So if I start from the beginning, there we go. So whenever I have a patient in my clinic, I always start from some anatomy just to get some kind of orientation a little bit. So if you kind of think of the eye like a camera, you've got a lens here at the front, so that light comes in through here. You've got a lens at the front, and you've got the film at the back. That's the retina, that's the yellow layer, and that's essentially the bit that takes pictures. And underneath the retina, you've got this red layer called the choroid, and that basically is the biggest blood supply of the retina. So without the choroid, the retina doesn't see anything because it doesn't have a blood supply. And the uvea, if you've ever heard of uveal melanoma, the uvea comprises the iris, which is the coloured part of your eye, and the choroid. So it's all this red structure. But most of the melanomas we see are just in the back part of the eye, so not involving the iris, just the choroid, which is at the back here. Okay. So that's where we start. And these melanomas can, so if you look at this as the normal back of the eye. So if this is your retina, this is the film in the back of the camera. Everyone's got this yellow disc at the back. That's the nerve that sends messages to the brain to say that you can see. You've got blood vessels that come off that nerve. And right in the middle is called your macula. That's the bit that you see detail and colour with. And the rest of your retina is a bit rubbish, really. It just sees shadows and shapes and stops you bumping into things and tells you you're in a room or you're outside. But if you want to do anything detailed like reading or writing, that's where all that vision comes from. So this is what a normal retina would look like. Melanomas can come in all sorts of shapes and sizes, and so these are the kind of lumps and things that I see inside the eye. So again, you've got the nerve here and the macula here. You've got melanomas that look like this. Some of them have yellow stuff over the top of them. That's called drusen. Some of them are pigmented, so they're a dark color. Some of them have orange stuff over the top of them. Some of them aren't pigmented, so they might be pale or yellow, and some of them are bigger and some of them are smaller. What makes sense, though, is that even if you have a big tumor like this is quite a big melanoma, at some point it must have been a small melanoma. They all start off as a single cell at some stage. So it doesn't really make sense to say a big melanoma is this and a small melanoma is that. They're probably all a continuum of the same kind of pathology. So this big melanoma must have started off as a little dot at some point, and we've just picked it up when it's a bit bigger. So we're doing lots and lots of treatments now to try and maintain people's vision, get them better vision after they've had treatment for these bigger and bigger melanomas. So we're removing a lot less eyes nowadays, and we're giving injections and things into the eye. But that's really for the big tumours. The question is, what do we do about the little ones? And the whole watch and wait scenario of this is a small tumour, let's just watch it. It's a little bit old fashioned, but it's still quite prevalent across quite a lot of the UK and Europe, actually. And the reason why is because in the past, it was thought that realistically, by the time somebody comes to see me with a lump in their eye, if they are going to get cells going through their bloodstream into other places of the body and metastasizing to the liver, for example, that process has probably already happened before they get to see me. And the reason why people thought that and still think that in many cases is a couple of different bits of evidence, really. And if you look at how old some of this evidence is, some of it is 20 years old, some of it is 50 years old. So it is quite old evidence, but it's the stuff that we still kind of refer to when we're talking about these things. So if you take all melanomas, very few people have metastatic disease by the time they see their ophthalmologist. Usually that disease happens later on in the disease process. So that doesn't really make sense, does it? If you take an eye out here and they've got a big tumor and you enucleate the eye here and you remove the whole tumor in one go, Why is it that 2 years later is when the majority of patients get their metastatic lesions? So it must be that before this process happened, before you took that tumor out, some of those cells must have escaped the eye, gone through the bloodstream, and traveled to the liver. So actually, does removing that tumor and removing the eye make a bit of difference to your outcome? And a lot of people would say, no, actually, this whole process of removing the eyes to control the tumor in the eye, but actually it doesn't make a difference to whether people get metastatic lesions or not. The other thing that goes along with that is if you take blood samples from every melanoma patient that walks through the door, quite a significant proportion of them will have melanoma cells in their bloodstream already before you've even done anything to them. And so that does suggest that there are quite a few patients where that you have missed that window and those cells have already escaped the eye and have gone into the bloodstream. So that's another reason why people go, actually, it doesn't make a difference when I treat these small lesions. I can't make a difference to this. And then you go into kind of more mathematical modeling where you go, okay, I've got a lump, it's in the liver, it's this size, and tumors of melanomas grow at this rate. And if I go backwards in its lifespan, it would have been a single cell around here-ish. And it's a modeling thing, it's not really based in real life, but if you kind of guesstimate, it looks like that single cell lodged in the liver quite a number of years before you got those metastases, and probably quite a long time before your melanoma was even picked up. Okay, so based on all of this evidence, it's a lot of people have said actually by the time people come and they get their melanomas treated, if they're going to have cells in their bloodstream and they're going to get metastatic disease, that ship's already sailed. That's already done. We can't do much about it. What we do know, however, from a lot of studies, and this is from the guys in the US, and they've just got more numbers than everybody else, but this has been shown in quite a few studies, is that the smaller the tumor, the lower the risk of getting metastatic disease. So if you have tumors that are very small, the chance of you getting metastatic disease is about 20%, depending on what size you're looking at. If your tumor is very big, the chance of you getting metastatic disease is a lot higher. And the question is, why is that? And I would argue that it's because if you treat them earlier, maybe you're stopping people getting metastatic disease before they get to this stage, where actually they've lost a lot of cells into their bloodstream. Okay. And if you treat them here, it's a bit like turning the tap off. Even if you've lost a bit of water down the drain, until you turn that tap off, those cells are still escaping into the bloodstream. But there's a couple of things that maybe confuse us or confound that a little bit. And so we had a look at all the patients who are diabetic, and the advantage of diabetes, a lot of diabetic patients get a lot of other health problems like heart disease and high blood pressure and blah, blah, blah. But the advantage of diabetics is that they get screened a lot. Their feet get looked at all the time, their blood tests get looked at all the time, their blood pressure gets looked at all the time, and their eyes get looked at all the time. And so actually a lot of those diseases that are not diabetes related get picked up a lot earlier than other people in the normal population who might not know their blood pressure's high, who might not know they've got a melanoma, for example. And so diabetics get their eyes photoed every year. The majority of my patients who are not diabetic, their melanomas will get picked up because they're getting some symptoms, their vision's not quite right, or they're getting flashing lights or something, or they've been to see their optician after a couple of years and the optician's picked it up. The advantage of diabetics is that they will get picked up a lot sooner because their eyes are photoed every year. So way before they even get symptoms, they will get their melanomas picked up on the photos. And if you look at how likely they are to get METs, they're much less likely to get METs than the normal population of people who have melanomas. You would argue because they're picked up earlier, not necessarily because they're more or less dangerous, but just because if you pick them up early and you treat them earlier, surely then you are stopping them getting metastatic disease. Okay. But like I said, it gets a bit confusing when you think about dangerous tumors and less dangerous tumors, and what are called lead time and length time bias. And so people who are screened look like they live longer, not necessarily because they live longer, but because you've picked up their disease earlier. So if you have the same patient, okay, here, and one goes through diabetic screening and they get a photo taken here and somebody goes, oh, you've got melanoma, let's treat you here, and they end up dying for whatever cause here, okay? And that survival time, it seems quite long. Okay. If you have exactly the same patients and you haven't photoed them and they eventually get problems with their vision and they last a bit longer and then eventually they get some flashing lights and they go see their optician, you pick up the same lump here. Okay, so you don't pick it up here, you pick it up a bit later, but actually they die at exactly the same time. But that survival time looks a lot shorter. So the question is, are these diabetics surviving longer because you've picked it up early and you've treated them and you've made their prognosis better, or is it just because they would have died at the same time, you just happened to notice it earlier? And so that is the argument of lead time bias. And a lot of people would say, actually, you know what, the reason why the smaller tumors are living longer is not because it's not a real length of time, it's just that you've picked it up earlier. So you can do some calculations to correct for that or guesstimate correct for that. It's very, very, very difficult to correct for that in reality because the best form of medical trials is to essentially a randomized controlled trial where you go, okay, you've got this section of patients and that section of patients, you treat one and you don't treat the other and let's see what happens to them. And obviously that's never going to happen, that you just leave one section of patients. So we'll never get that answer definitively to say, if you left these patients untreated, this is what would happen to them. So these are the kind of best types of evidence we're going to get, and we can do some statistical analysis to try and get round these kind of factors. So we did a couple of calculations for that, and the diabetic group still seem to survive longer from their melanoma because they're picked up earlier, even if you try and correct for that lead time. The other problem is what's called length time bias, which is a little bit different. So some people would say, actually, these small tumors that you're treating, they were never dangerous to begin with. The big ones are dangerous, the small ones aren't dangerous. They never would have killed you anyway. You're treating loads and loads of tumors that never would have done anything. And it looks like their survival is longer, but actually the disease is just generally more benign. And so that comes down to really the genetics of it. And so we come down to some of the genetics of melanomas. And if you look at melanomas, the things that predict how likely you are to get metastatic disease, things like how big the tumor is, where it is, the size of it, and age and gender and things like that, they are important, but actually the strongest predictive factor of how likely you are to get metastatic disease is the genetic makeup of the tumor. So if you get somebody like this, and this is just an arbitrary random person, a lady who's about 60, who's got a tumor of a particular size of about 5 millimeters thick or so, and if you say that all ladies of about 60 will have a mortality rate of about this over 8 years, okay, this is the general population of that particular age group. If you don't take a biopsy, you can kind of guesstimate for this particular size of tumor, this is the mortality rate from metastatic disease. It's about 30-odd% over 8 to 10 years. Okay. But if you actually know the genetic makeup of this tumor, you can be a lot more specific about that and a bit less guesstimating. And so by far and away, the strongest genetic factor that's involved in this is the chromosome 3 status. And so disomy 3 basically means that you've got 2 normal copies of chromosome 3 in that tumor. And if you've got exactly the same lady with exactly the same tumor in her eye, but she's got 2 normal copies of chromosome 3 in that tumor, you can see that her survival rate almost 100% matches everybody else of her age and gender. Okay, so her increased risk of mortality is pretty much minimal. If, however, you've lost 1 copy of chromosome 3, that's called monosomy 3, so you only have 1 copy now. Most people will have 2 copies of every chromosome. This particular tumor has lost 1 copy of chromosome 3. You can see that this is her age and match population, and this is her risk of mortality over the years. It's drastically different. And so if you have this mutation, the chance of getting metastatic disease is much, much higher. So this chromosome 3 status is the strongest predictive factor of how likely you are to get metastatic disease. So if you kind of take all of those factors together and go, okay, some of these tumors, if you pick them up early, maybe you're just picking them up earlier and you don't survive longer. And actually all of these small tumors are benignish anyway, so they would never have killed you anyway. If you just look at the patients who've got monosomy 3 tumors, then if you just look at the ones that genetically are high risk, does size then make a difference? Because those are, we know, high risk tumors. And if you treat those earlier, does that make a difference? And so that was kind of the basis of this paper that we published a couple of months ago. So this is a small tumor. You can see on the ultrasound, tiny little lump there. That's a tiny little tumor. And we take a couple of biopsies. Liverpool probably do by far and away more biopsies than anybody else in the UK, possibly more than a lot of places in Europe. And so this is taking a biopsy through the retina, going into that choroidal tumor there, and taking a sample and sending it to Sarah, basically, who can look at some of these cells and tell me whether it's definitely a melanoma and what the genetics are within that tumor. So if you just look at small tumors, so take tumors that are less than 2.5 millimeters in height, and you look at what we're doing with those. We've treated about 1,200 of those over the last 15 years. That's quite a lot of actually very small tumors that we treat. And I would probably say that a lot of people wouldn't have treated all of those and would have watched a few of those. And that's kind of the point. And of those 1,200 cases, we probably got a biopsy result with a chromosome 3 analysis of those tumors in about 15% of cases. Whether patients wanted them or whether they were just too small to get a result or whatever, we've got results for about 200 small tumors, which is the largest lot that you've got in the world, essentially. And of those 200 small tumors, over a quarter of them had a monosomy 3 mutation. So what does that tell you? What that tells you is that if someone says this is a small tumor, it's benign, it's never going to cause you problems with your liver, that's not true, is it? What it means is that a quarter of these patients, or over a quarter of these patients, have a very high risk genetic mutation, even though their tumor is really small. Okay, so that kind of myth that small tumors are all benign is not true. If you look at how likely patients are then to get metastatic disease, these are the monosomy 3 lines, these are the disomy 3 lines. So if you just look at the ones that are high risk genetically, these are the larger tumors over 2.5 millimeters. These are the smaller tumors less than 2.5 millimeters thick. You can see the risk of dying of metastatic disease goes from about 65, 70 odd % down to about 35%. That's quite a huge drop in metastatic disease. And so you would then argue, okay, these are not all benign tumors. And if you treat the high risk ones earlier when they're small, rather than wait until they're bigger, actually maybe you can prevent people getting metastatic disease. And so these are some of the statistical things, but if you kind of correct for lead time bias, like we talked about earlier, you'd say that actually the risk is about a third. So what does that tell us? What that tells us is that small tumors can be dangerous, and patients with who have small tumors with high risk mutations can die of metastatic disease. And so small tumors are not all benign. And what that also tells you, the earlier you treat them, theoretically, the better your prognosis. So how can we try and treat small tumors earlier? First things first, we've got to pick them up earlier if we can. And so if you go back to the diabetic patients who are screened and have their photos every year, it would be really nice if everybody could get their eyes tested every year. And it's very uncommon for patients, particularly if you don't have symptoms or anything, to go to your optician. And the recommendation is that you go every 2 years, but I know my husband doesn't go every 2 years. He just goes, my eyes are fine, I don't know what you're worried about. And I think there ought to be a little bit of a drive to promote people to go and get their eyes tested, really. Not just from a melanoma point of view, a lot of things you can detect from an eye test, from high blood pressure to diabetes to glaucoma and other kind of health and vision type issues. So let's get people going to the optician more and getting their eyes checked more. And once the optician has picked something up, it's up to the local ophthalmologist to really think about melanomas. And it's very easy to diagnose a big melanoma because everybody goes, oh, it's a really big lump, it must be serious. But actually the little melanomas are a little bit more subtle, and people just need to be a bit more aware that these could be melanomas, and all of these are melanomas, even though some of them are small. And even though they're small, they could be potentially dangerous. And that means they need coming to an ocular oncology centre ASAP, really. And what it also means from an oncology centre point of view is that we always shift our focus to, oh, it's a really big tumour, we need to treat it ASAP. And for some reason, there isn't that mentality of it's a small melanoma, we need to treat it ASAP. And I think that's where our brains need to shift to a little bit, is that if we do think it's a melanoma, even though it's small, it still needs treatment. And that's the discussion to have with the patient about the risks and benefits of treatment. But realistically, if you're going to try and prevent metastatic disease, this is the only way we can do that. So this is a plaque, a radioactive plaque. So if I kind of summarize a little bit, so we know that smaller tumors do better. Patients with smaller tumors do better. They get less metastatic disease. And that's not just because they're all benign. Some of them have very dangerous genetic mutations. And actually, if you treat those ones with high risk genetic mutations earlier when they're small, patients do better than if you wait for them to be bigger. So this is the ocular oncology team in Liverpool. So you've got me and you've got Professor Hyman, who runs the service. And then obviously you've got Sarah, who's basically the one who takes all these teeny tiny biopsies that I send that most pathologists would just send back to me. And she manages to get some kind of result out of it so that we can look at these things a bit better and give patients their results in a more accurate fashion. So that's probably where I'm going to finish. Don't know if you have any questions.